Dr. Ali Ziegler, Dr. Angela Morin, correct? Yes. Thank you. And they're going to tell you more about themselves, but I did want to let you know, if you want to send in some questions, you can use this QR code. We'll have it on the back if you don't want to raise your hand. Just so you know, we do live stream this on Facebook. It will be up on Facebook for the next 30 days, and then we move it on to our UAS Ketchikan YouTube account. So the only ones who are going to be in the video portion are two doctors right here, up here. But if you ask a question and you don't want your voice on the audio portion, just send in your question or come tell me and I will raise my hand.
Cool.
Okay, so welcome to Ask UAS and the campus library.
Hi. Thank you everyone for coming. I'm so happy to see so many people here. So I wanted to introduce myself just a little bit, share about my background. I have my PhD in psychology and women's studies, and my research background is heavy in sexuality-related studies. So it's like very broad. My research is pretty broad. I now teach a variety of classes related to sexuality, but also lifespan development, and so this topic of menopause is kind of like right at the intersection of a lot of courses that I teach, but also I'm a middle-aged woman. And so I have just a general personal interest in learning more about this topic, and so that kind of urged me to touch base with Nicole and see if she might be interested in chatting more about this, because I don't know the biomedical end of things. I do more of like the psychosocial, emotional end of things. Our audience is all of you. This is who we wanted to see. Anyone that wants to know more about this, this is intended as like a 101, right? Like, I know that I didn't get a very solid education in any formal context on menopause, and I imagine that's true for most people. And so this is really going to be basics. We got some questions beforehand, so thank you to anyone that submitted those. They were anonymous. Kathy just shared the QR code if you want to submit more. And so we're hoping to cover those as we talk. If we don't cover those during the talk, we'll come back to them later. If you have questions, you can raise your hand at any point. We can get to those. We do have slides prepared, but I'm open to seeing what people want to know more about. Yes, I'll hand it over to Nicole to introduce herself.
I'm Nicole Morin. I'm an OBGYN. I've been here now in Ketchikan for almost 10 years, and I appreciate all of you taking your time to come. I hope we can address your questions, concerns, needs, and if we can't, we do want to know what else you want to know. So if there's things that you feel like we didn't cover, you'd like to hear more about, let us know. And thank you to everybody who helped to get this going. It's, I think something that is much needed to talk about, not just with all of you lovely women, but with the partners. So thank you for showing up. And, I encourage if we continue to do a series on this, that you encourage your partners as well to come.
Yeah, and we will use the term woman when we're talking about people that experience menopause, but we recognize that the experience might exist for other folks and that not all women have a typical experience of menopause. So that's kind of the shorthand, but I want to make a note that that's not always the most inclusive term either. Thank you. Okay. All right. So we're going to kind of just be going back and forth.
So I think the question of what is menopause is very broad, but there is actually a specific definition of menopause, and it's actually retrospective. It is the last time you have a menstrual period, and we don't know that that's going to be the last time that we have it when we have it, so it's something that we would diagnose kind of, retrospectively, and it's 12 consecutive months without a period. However, it is on a continuum, as some of you may be experiencing right now, and there are some, more widely accepted, process that starts, and we'll talk about this a little bit more, sometimes as early as your 40s, your early 40s, and then continues on into what we call the postmenopausal period and beyond. So when we talk about menopause, I just kind of wanted to geek out for a minute because I don't know how much of this education anybody really gets. But the process of having a regular menstrual cycle is a huge coordination of a bunch of different hormones. And if you see on the right side here, we start with the onset of menstruation, that's considered day 1, and then you progress through this process of very finely regulated hormonal fluctuations. And this whole gamut of regulation on the left, starting with your hypothalamus, going down into your pituitary, and then down into your ovaries, and just the immense coordination that this requires. I think it's also interesting to note that we have, and a lot of this is regulated by the theca and the granulosa cells of the ovaries. Those are actually the cells that are surrounding your follicles. So you have the theca cells on the outside and the granulosa cells on the inside. And you might see some hormones that you recognize like estradiol, testosterone, and progesterone. And those are kind of the things that we focus on mostly in our hormone therapy. But to note that, there are a lot of other hormones that are there that participate, and the upregulation and downregulation of those hormones are something that over time, as we get closer to menopause, get dysregulated. And so when we're 6 to 9 months or so in utero as little fetuses is when we have the most of these follicles that we're ever going to have in our life. And after birth, there is a large programmed cell death of many of these cells, the majority of them actually. And so after that time period, once we get into actual menstruation, we get recruitment of these follicles, and you can kind of see that on the top. How you have these recruited follicles, they mature, we get a dominant follicle that ovulates, and typically it's only 1 a month that makes it to that mature stage and ovulates. And then we have the corpus luteum that supports pregnancies or dies, for lack of a better term, a more scientific term, and degenerates, and then the cycle starts over again. And so as we go through our reproductive life cycle, these cells, the granulosa cells that help to produce estradiol, and the theca cells that produce the androgens and the progesterone, they're not here forever, and it's this process where we eventually start to kind of run out of follicles. And that's where our brains start to try to scream at our ovaries, and we see this increase in FSH, trying to tell our ovaries to make more estrogen, and our ovaries and our follicles are just not really responding anymore. And so that's kind of the basis of the perimenopausal and menopausal period. When does natural menopause happen? So normal menopause is between ages 45 to 55 typically. You can start to be symptomatic years before that and years after that. Average age in the United States is about 51. Early menopause is from 40 to 44. And then premature menopause is after 40. And I just wanted to mention a few things. Allie and I were just talking about this, that, the kind of the best predictor of when you're going to go through this is kind of when did your sister go through it, when did your mom go through it. But there are other factors that can alter that, such as smoking, early life stressors, domestic violence, race and ethnicity also have a contributing factor. We're not going to talk much about premature menopause. There are genetic factors that play into that, and we're still kind of, learning about, what contributes to premature menopause, and often that's pretty devastating for patients or people, women, because they want to have kids and they can't anymore because they're not ovulating anymore. So it's kind of a separate, kind of larger topic. And whether you go into menopause naturally or you go into menopause some other way, you may experience symptoms with more of a sudden onset if you have something like surgical menopause, or you're going through chemotherapy that's affecting your normal hormonal cycle. Radiation can also damage the ovaries and cause you to go into menopause. Drug-induced, it's typically reversible, but not always, separate from chemotherapy. And we may actually prescribe medications to stop you from having a period for different reasons. And then stroke, disruption to any of that cycle of the brain can lead to early menopause also. So what are the symptoms of menopause? So typically in the early stages, you can have shorter menstrual cycles, you may have lighter periods. So instead of having normal 28-day cycles or 31-day cycles, you might be finding that you're having a period every 21 days. And your bleeding might be lighter, it might be heavier, it might be completely erratic. You might go months without having a period and then have a really heavy, painful period. Vasomotor symptoms, also known as hot flashes, and those can occur kind of in tandem with irregular periods, but can also, come a little bit later. I think it's important to note that these symptoms can be variable in presence, so not everybody has all of these, and some people don't have any of these. I mean, sometimes you go through menopause, just sail through, and you don't have any of these symptoms. I think one thing to note is that if you have heavy and irregular bleeding at any time, you should probably go see someone, a physician or, a nurse practitioner, and have that investigated, because while if you're of the appropriate age, that is likely menopause related, but could be something else like a polyp or hyperplasia or fibroids or, endometrial cancer. And so we want to make sure that, you're progressing through this fine and that there is not anything else to worry about. Mood changes, it can be, irritability, it can be mood lability, where you're completely emotional, you can't control things. You might be depressed, you might have increased anxiety. All of these things, you can experience and can be a part of these hormonal fluctuations and this transition in life. Sleep disturbances, typically insomnia, would be directly attributable to hormones, but you may be noticing other things like the hot flashes are waking you up at night and that's causing you to have sleep disturbance, or you're having increased urinary frequency, or any of those things can contribute to sleep disturbance, which doesn't make the mood changes any better or the vasomotor symptoms any better. It doesn't make the brain fog any better, and brain fog is kind of this general term that we use to describe just kind of you're just not as sharp in your mentation as you used to be. You might not be remembering things as well as you used to. You might not be able to organize your thoughts as well. Genitourinary symptoms, this is most directly just lack of estrogen to the vagina and the urinary system. So you can have vaginal dryness, you can have increase in urinary tract infections, you might notice an increase in urinary incontinence, or perimenopause. Anyway, so genital urinary symptoms can be really uncomfortable and can be difficult to talk about. We will talk about it a little bit more here. Weight gain, is also a natural process of aging, and I think that this one is tough because just generally as we age, we tend to decrease our metabolism just naturally as we get older. I think that a lot of people think that, if I get on hormones, the weight gain is going to reverse and I'm, going to go back to my perimenopausal weight, and it's not quite the case. We can talk a little bit more of that later. And then it's important to note that, also during this time, in this time of our lives, there can be also additional life stressors, and I think Allie's going to talk about this a little bit more. But just to know that all of these taken together, and this is not an exhaustive list, you see there's, can be many more things here, but I think it's important to note that these can have effects, whether the depression, anxiety, isolation is a symptom of these symptoms or a result of these symptoms, or whether it is innately part of the hormonal fluctuations. I don't know that we'll ever know the answer to that, but certainly the decreased libido, the mood changes, the feeling of isolation are all real. And I think especially, the decreased libido and the isolation, taken together can be pretty, alienating as we go through this process. And we will talk a little bit about decreased libido as well. I think that that's probably the number one thing that there's a lot of things that patients talk about, but I think that this one is the one that is the most troubling for people, is when they feel like they're not connecting with their partners the way that they used to, and that they feel guilty about that. They want to be intimate and they want to be a good partner, but sometimes it's just not really easy for a variety of reasons, right?
So hot flashes, I think, are kind of the hallmark symptom of perimenopause that most people are familiar with. I think that's the first one that I knew existed. And they are the most common, so people do commonly experience hot flashes, but that is not like an exhaustive range of experiences, nor does everyone experience hot flashes. So hot flashes can be really uncomfortable, as can a number of the other symptoms associated with perimenopause, and that's kind of one of the reasons why we're talking about it, one of the reasons why people come and see their provider, because they're concerned about the specific symptoms they're experiencing. And when we think about perimenopause and menopause, we think about how it is this reproductive change. I mean, that's, I think, largely how I hear about it defined, right? Is like, you can no longer have babies. That is part of how we define it. But it has an impact on other systems in your body as well, like Nicole was talking about. So there's neurological impacts in addition to the reproductive system that's being impacted, in addition to other things that are occurring too. So it's not just about reproductive changes. It affects your entire body. And perimenopause is when the fluctuations are occurring more so, right? Like leading up into that moment of menopause that Nicole mentioned. That may last 4 to 10 years, where you are experiencing hormones going up and down, and that can lead to some of the severity in these symptoms is not just that like your hormones are dropping, but that they're going up and down, right? And so that impacts how you're experiencing everything, right? Like your moods, your brain fog, your libido, all of those things are going to be impacted by these changes. Nicole mentioned, this menopause brain, this brain fog. This is a common symptom that people will experience. Nearly 60% of women report difficulty coordinating, concentrating on, or having memory lapses during this transition. So 60%, I mean, studies vary in what percentages they report, but 60% is like a very high number of people to be experiencing like brain symptoms, right? Like that interferes with our ability to function on a day-to-day basis in our home lives, in our community, in our jobs.
Question.
Yeah.
You just said during the transition. Does that mean brain fog goes away once you hit menopause? I just want to clarify.
I mean, that's a great question. I looked at some studies. So a lot of the data aggregates perimenopause and menopause. And so there aren't a ton of studies where they're looking at peri versus post. What I saw, not really.
I think you just get used to it.
Okay. I mean, I think it might be worse during perimenopause according to some of the studies that I reviewed, because of, I imagine because of the fluctuations, right? So it's like unpredictable in this way. But yeah, it did seem like it's gone once you hit that period. I loved this quote. This was from a qualitative study that I reviewed. Very relatable. Everything people did irritated me, so I stepped back. So rage is one of the symptoms that people report experiencing during perimenopause. I think more of like the mood symptoms are more commonly present during perimenopause and tend to kind of resolve, maybe the wrong word, but aren't as common in the postmenopausal period. But yeah, experiencing rage, which like we were talking about libido. I mean, angry people typically don't want to have sex with their spouses or their partners, right? Like these things are all interrelated, and it's not just hormonal that is impacting how we experience the symptoms. Okay. Yeah, I think, rage, I think, is a really interesting symptom that I think oftentimes doesn't get overlooked. Anger just isn't conceptualized in the same way as other emotions oftentimes. So when you're thinking about depression, rage can be a symptom of depression. And so it makes sense that it would be a part of this experience for some folks. There are also social impacts. So for one, this is kind of a busy time period for a lot of people. They may have a lot of other life changes happening, whether that is job-related, relationship-related, sandwich generation. I mean, I've been hearing that term for decades now. So that typically is referring to folks that may be raising children in their home and also having to care for their aging parents. So you're going to sandwich between those. So it's a lot of caregiving responsibilities placed in one, or that age range. And then this relationship and identity changes. So folks may be leaving the workplace just because of the timing or because they're experiencing some symptoms that are interfering with their ability to work. And so you might be experiencing identity changes related to like your work self. Like a lot of people, that is a big part of their identity. And so if you're shifting careers or leaving the workforce, that is going to impact how you feel about yourself. There are changes in physical capabilities just as the result of aging, as I'm sure a lot of us have experienced. That can impact how you feel about yourself, how you identify, what activities you might be participating in. And then we also might have different feelings about our bodies and our sexuality that also impact our identity and how we relate to our social world. And then there's the emotional impacts, which are also very big, and we've touched on that a little bit with some of these fluctuations we've talked about, but there's a subjective response to our physical changes. So if someone is going through perimenopause and they're finding that their body is changing, some of those experiences might be challenging because, I just can't walk upstairs as quickly as I used to be able to, and that interferes with my day-to-day life. But some of them might be more like, my body is changing as I age, which, on the surface may not be a big deal. However, when we live in a culture that values youth and thinness, and we're no longer fitting into that category, it's going to impact how we feel about ourselves. And so our interpretation of what is happening to us has a big impact on what that experience looks like for us.
And there can be other health implications, some good, some bad. I mean, I think that we can all celebrate not having periods anymore. I think we can all celebrate not having to worry about birth control, and some of us might be excited about not having to worry about having babies anymore. But on the flip side, there can be other health impacts. Also, some people may be very disappointed that they can't have any more babies. We do tend to see a rise in cholesterol and lipids, increase in blood pressure, increase in heart disease. Osteoporosis is a big one, and a decrease in metabolism that you kind of talked about earlier. This is actually Erin. She is deadlifting 352 pounds in this picture.
Yeah,
So,
round of applause for that. Bone health is important, and you don't have to deadlift 352 pounds to get the benefits of strength training, but
it doesn't hurt.
it doesn't.
It doesn't hurt. It definitely doesn't hurt. And so we're going to kind of talk about some of these things that can help ease the transition, medication, hormonal and non-hormonal, lifestyle, and social support. And we were talking about lifestyle a little bit, and I just want to say, as someone who could improve my own adoption of any of these things, but it's never too late. You can always recruit your family. It's good for them too. But I think some of the things, and I don't want to say diet in particular, but more lifestyle, right? Like the sweets and everything that we might be craving and all those things that we're going, that we want to eat. We might feel tired and, our willpower is not great. And so we might be eating things that we, typically wouldn't be eating. We might be with a bad mood and the food makes you feel better. You just feel like you're craving it and you want it. But these are some of the things, if we can help you with the medical side and the hormonal fluctuation side, that these things can also contribute to, just feeling generally more well, mental clarity also. And so moderating your carbs and, some people talk about the anti-inflammatory diet, decreasing your gluten intake, increasing your protein and nutrient-dense foods. I think this is often tough for us to do in busy lifestyles, is to really pay attention to what are we putting in our bodies to make us feel good and to check those boxes for the nutrients that we need. But we do need them, and we do need water, and we need sleep. And so these things sound pretty basic, but I bet if you paid attention, most of us are not doing these things as a regular, facet of our lives. Daily exercise, I do not walk 20 minutes a day straight, ever, on a daily basis. It's really terrible. It's terrible, but you've got 2 kids at home, you've got a busy career, you still want to be keeping up your household and all the other demands, kids' activities, all that stuff. So it's tough. And so while I'm saying all these things, please don't think that I'm judging anyone if you're not doing these things, because really, it's a lot. It's a lot. But it's really good for you too. So not to downplay that this is good stuff.
I hate to be the question, but you put all those things up there, but not all of us are dietitians. When you say moderate carbs, what does that look like? When you say increase protein, what do you have like a, here's the goal?
So I don't know that there's great evidence that this is the minimum amount of protein that someone needs at this age, right? And so as we go on to maintain our muscle mass, we do need to increase our protein. Part of that is exercise, but part of that's having the building blocks to keep that stuff present in our bodies. I'll shout out 60 to 100 grams of protein a day is probably what you should be aiming for. And then, carbohydrates, those are really hard to avoid because they're in all foods, but carbohydrate-rich foods would be like pasta, rice, bread, cereal.
So all the good stuff.
Right, like all the stuff that you crave when you're like, you just want some comfort food because you had a bad day. Or you have kids and they're having macaroni and cheese and peanut butter and jelly, and that's like the best food on earth. So it's really hard to resist that stuff, but it's not the best for your kids either. So, just being mindful of it and, making better dietary choices. Nutrient-dense foods, colorful things are nutrient-dense typically. That's a good way to kind of think about it. So you've got, bell peppers, carrots, leafy greens, peas, those kinds of foods, are generally good things. Kale, things that don't come in a box typically. These are things you can probably look up. Supplements too are okay. If you need to take a daily multivitamin, that's a good start. But yeah. I don't know. If anybody wants more, like my or our spiel on, things that we need to investigate for good nutrition, we can talk later. But also we have dietitians. And they're also fabulous, and they're very underutilized. And so if you have those kind of questions and you really want some one-to-one time to really kind of figure out what would work for you in your life, a dietitian is invaluable. We have a really great one at Peace Health. I'm sure that they have them in telehealth places too. I'm sure they do that. I haven't actually.
Yeah, they do.
Do you have to be referred for dietitian, or can you?
I think it depends on your insurance. Some insurance companies don't require it, but I would be really hard to imagine any doctor that would not say you want to go see a dietitian, sure, and would be happy to place our referral for you.
Erin, did you have a
I was
question?
just going to add that KIC also has a dietitian.
Oh, good.
If there are people who access
Great.
care through KIC.
Yeah.
There's one. Yeah.
Yeah. If anybody else knows resources in the community or.
I think Janae Meyer.
Oh, yeah, Janae does dietitian.
Yes,
Yeah,
Private clinic.
totally, great. Yeah, Janae, she does a lot of great things. And then social supports, I think that, as we mentioned before, the feeling of isolation, the feeling of like I'm just not myself and I'm crazy and I just want to withdraw so that I don't hurt the people I love and I don't get labeled as crazy or, it's a real feeling that, and I think that talking about it, letting people know what you're going through, trying not to hide it, and hopefully you can gain understanding from people, especially the people that you love that are close to you. Just this is what I'm going through, and I think that education also is very helpful so that people just generally know kind of what this time can be like for us. So talk to your friends, look around you. These are probably all the people that you could find support from if you need it. Talk therapy is another avenue just to learn how to kind of, if you haven't struggled with some of these emotions going through your life, or maybe not in the scale that you're experiencing them through this process, Talk therapy, cognitive behavioral therapy can be really helpful. And then social support groups, and I hate to say, look on Facebook, or, go to Reddit, or, look in the community. When we did the radio show a few weeks ago, we really were like, I don't know what to tell people about the social supports here in Ketchikan. It'd be really great if somebody wanted to start a menopause support group. Maybe go for your 20-minute walk while you're talking about your terrible hormonal symptoms. But I think your sister, your mom, your friends, maybe even your daughters, if you have those people in your lives, aunties, can be just people to say, hey, I'm going through this and I'm really struggling, and just somebody to offer you some understanding and maybe a little bit of, feeling included and camaraderie can be super helpful. Okay, medications. This is like the moment you've been waiting for. So these are just kind of the preparations, and I think that it's important to note that there are a lot of studies out there about this. Some of them are good, some of them are not good. Many of them, I'm sure, are accessible through the library. Thank you for that resource. I think it's really hard to find good resources. PubMed, search menopause, read. If you can get free access to library resources, a lot of the articles, the research articles that go through this stuff, they're tough to get through, but there are a lot of meta-analysis that kind of condense a bunch of articles, and if you can kind of plod through it, you might make some sense for you. The ones that I like most recently is the NICE guidelines out of the UK. I think that they've done a really good job of taking a whole bunch of information and condensing it into a little table that you can read. And so if you want to peruse the NICE guidelines specifically on medications for the menopausal transition, I think it's a really good resource. Some of you may have heard of the Women's Health Initiative or the Nurses' Health Study. Those are some really bigger, better funded studies that happened, decades ago now. Also, some of that data is good, some of that data is bad. I think that was the initiation of saying hormones are bad for women and we shouldn't be giving them. I think that we've kind of reprocessed that data in a way that shows that, hormones might actually be beneficial. And sorry to all those women who missed the vote on that, but, that there really can be some benefits to getting on hormone therapy through menopause, especially if you're early menopause or surgical menopause and you're really younger. I mean, the effects on bone health, cardiovascular health, I think that those are coming out to be real things that are beneficial. So estrogen, progesterone, testosterone, vaginal DHEA is actually an androgen, so a male hormone, but can be used for the vaginal dryness, which this is actually pretty new to me. I've never prescribed it before, and I think it's kind of interesting, so I've got to read more up on that myself. Preparations that are FDA approved include the oral preparations of estrogen, the transdermal patch, and vaginal estrogen. These other ones here, the creams, the spray, the troches, the pellets, the injectable. Well, injectables are also FDA approved, but they're not used widely because they have side effects that are not desirable. So I just want to point out here that there's many ways to skin a cat. I think that when we in Western medicine, we look at these studies and we want evidence and we want information to know that these things are safe and they're effective, we do studies. And I think that there are a lot of providers out there that are very well-meaning and they want to do good things. And so we've developed these other bioidenticals, and bioidenticals, which is kind of a misnomer. Like most of the preparations of these are bioidentical, or become bioidentical as we process them in our own bodies. And I don't want to say that there's a wrong way or a right way to do this. I think that whatever you find is helpful to you and makes you feel like you're getting listened to is probably the most important thing, honestly. If you feel like you're getting what you need and it makes you feel better, I think that there's not really a wrong way to do this. I do think that if you want to do bioidenticals and you want to do kind of micro adjusting doses and be watching your levels closely, that is one way to do it, and I think it's fine. You know, with these FDA approved and very regulated medications, the dose that you're getting is a stable dose. We know the pharmacokinetics behind it. You know, we know what the safe range is. And it kind of takes out a lot of those like needing to get hormones checked all the time and having to micro adjust your dosing and all that stuff. So I'm not here to say that one way is better than the other, just, you know, there's multiple ways to do it, and I wouldn't tell anybody that they shouldn't be doing what is working for them at this point in time with the evidence that we have. There's not a ton of good evidence about the bioavailability and the pharmacokinetics of some of these other, like the pellets and the injectables and the troches that are the oral little, like lozenges that you can take. So progesterone is a hormone that actually its main function in hormone replacement therapy is protecting the uterus from the estrogen that you're taking that is going to help all your symptoms. So if you have a uterus and you're taking exogenous estrogen to protect the lining of the uterus, you need some progesterone on board. There are different ways to get progesterone also. There's oral, there is the patch can be a combination patch, it can be an estrogen patch alone. There are also creams, sprays, troches, and then the IUD, the progesterone-containing IUD. If patients don't tolerate the oral or the transdermal progesterone, or they have some contraindications to progesterone, which there aren't many, but the IUD is a sufficient alternative, and you know might actually end up being the way to go at the end of the day.
What's a troche?
Troche is like an oral lozenge or a film that you take orally, like absorbed through the oral mucosa. Testosterone, mostly this is compound topical creams. There is oral ester test that is FDA approved, but it's not good for you for the most part. The testosterone taken orally is not good for your cardiovascular health. It makes your lipids increase, and I mean, some people probably can tolerate this okay, but just from a population standpoint, we tend to not. Typically don't prescribe the ester test. And then the compounded topical creams, I think there is a testosterone that is a cream that is about 10 times the dose that we should be taking as women for our levels of testosterone, but could be scaled back and used very small amounts. And the testosterone, I would say, would be something that I would recommend getting tested regularly if you're taking testosterone. And then the vaginal DHEA for vaginal dryness and the genital urinary symptoms. So that's kind of what one of the patches look like. There's the ring, the estrogen ring, S-string, there's pills.
Yeah, Erin, did you have a question?
Oh, I had a quick question about the vaginal DHEA. So does that then circulate systemically, or
No.
it just stays local?
Most of the dosing of the vaginal preparations of hormone replacement are for local effects. You know, with estrogen, you know, you can dose it so that you would get, you know, higher levels systemically, but typically we use vaginal preparations for vaginal symptoms. Yeah.
If you've been advised to not be on estrogen birth control, would you also be advised to not be on estrogen hormonal therapy?
So we'll talk about that a little bit. Estrogen in the hormone replacement therapy is a lower dose than what you'd be getting in a traditional birth control pill. And so I guess it just depends on why you were told you can't be on birth control pills. The transdermal estrogen is so the patches or the creams or the sprays, anything that's absorbed through the skin instead of taken orally is looking like it's the safest thing for us to take. It's decreased risk of venous thromboembolism, which I think is a lot of the reason why as we age, we tend to have a higher risk of that with higher dose oral contraceptives, especially if we have increased weight or were smokers or have other risk factors, family history of blood clots, or there are some inheritable clotting disorders that you could have that might make it not great for you to be on that level of estrogen. Yeah. Non-hormonal medications. So I just want to say that for the vasomotor symptoms, that there's nothing like the hormones. I mean, hormones are made to treat the vasomotor symptoms or hot flashes. But as we talked about, some people can't take hormones. And if you've had breast cancer, you're taking tamoxifen, history of stroke, heart disease, heart attack, history of blood clots, you might, want to try some of these other methods to manage your symptoms. So SSRI, SNRI, so selective serotonin reuptake inhibitor, and the serotonin norepinephrine reuptake inhibitor. These are antidepressants, and they have been shown to be efficacious, some of them, to treat hot flashes. Paxil is one that if you're taking tamoxifen, you wouldn't want to use that. So if you have a contraindication to hormonal therapy and you want to try an SSRI, you want to avoid that one. So citalopram or escitalopram are the ones that have been shown to be more effective with a favorable side effect profile. Important to note, so these can treat hot flashes and also can help level out the mood disturbances and help with sleep disturbances. The side effects, though, can be decreased libido, and there's some other side effects to note. So if you wanted to start on that, definitely, talk to your healthcare provider. Newer, kind of these last three are newer medications, the neurokinin 3, and there's a neurokinin 1 and 3 antagonist. These act on your brain to tell your brain that you're not having a hot flash, help to regulate your body temperature so that you're not having the symptoms of hot flashes. These medications require some observation of your liver function, but generally are pretty well tolerated and can be helpful. Gabapentin is typically used for neuropathic pain, so pain from nerve damage or nerve pain, but has been shown to be, pretty effective at helping to abate hot flashes, and also can be good for sleep. And clonidine has kind of fallen out of favor. This is an antihypertensive medication, so to treat blood pressure, but can also help with hot flashes. So those are some of the non-hormonal options available. And then this is kind of that, like a lot of that in a little chart if we like these a little bit better. So medication across the top, indication. So estrogen basically treats a lot of the things. There is an increased risk of breast cancer with longer use. It is thought to be fairly negligible though. Clot risk is still there, especially if you're taking oral preparations, but benefits bone health, cardiovascular health, it's looking like, can help cardiovascular, prevent cardiovascular disease is what I'm trying to say, but increase in gallbladder disease is pretty significant. So if you start on hormones, you might need your gallbladder. Progesterone, like we talked about, if you're on estrogen and you have a uterus, you probably should be on progesterone. It helps protect your endometrium and can help with sleep. DHA is specifically for the genitourinary symptoms of menopause, so the vaginal dryness, increased urinary tract infections, pain with intercourse. SSRIs, SNRIs, so vasomotor symptoms and mood, help with mood and sleep, but can cause low libido. The neurokinin blockers, mostly for the vasomotor symptoms, but it can also help with sleep, but the downside is decreasing LFTs. Gabapentin can be really nice for pain relief too, because it is for neuropathic pain. So if you have that kind of pain, you might get a double double whammy there with that, and then quantity we talked about a little bit. Questions at this point?
There's a term, I looked it up, male menopause. Apparently is an acceptable concept, and it involves testosterone, I think, levels, and but that is a term that's used. So I just wondered if you had any comment on that.
I think we're focusing on menopause in women. I mean, that might be something that someone else talks
Yeah,
about.
I mean, I'm sure, and I don't want to like downplay the importance of that too, is that men go through the aging process just like women do. You know, that they have it as definitive as a end to the, to a phase. But yeah, I mean, I think that that's something that's important, and we should have a look at that. Sure, yeah. So when to start? So this is a big question. So do we start when you have hormonal abnormalities? And I put in this normal range of estrogen, estradiol, luteinizing hormone, follicle stimulating hormone. So there's a pretty broad range, and this is normal. These are reproductive age women, and so you can see that the range is pretty huge. And so that's why testing hormones sometimes is not very useful. Like you'd be having symptoms and really struggling, and your hormones are normal, and you're like, well, now what's wrong with me? And so I don't love to use this as a benchmark for when to start hormone replacement therapy.
And I found your answers really helpful in understanding like why these hormonal tests are not necessary generally. So for one, those ranges are huge, but also your individual ranges are going to fluctuate throughout the day, throughout the month.
And throughout the process of menopause. I mean, throughout this transition. I mean, you might be on your lab values totally menopausal 1 month, and then the next month you're totally normal again. And, that in and of itself can make you feel kind of crazy.
So being in the age group that, was not okay with hormones, is it something that, can you start hitting them at an older age, or do you?
That is a great question. And I think that what we're finding is that a lot of the information that told us years ago in the Women's Health Initiative that hormones were not safe is because we included a wide range of women that were over 60 who were newly starting on hormone replacement therapy. And so it's a tough question to answer because I think that those women are at higher risk of having cardiovascular issues that, can be compounded by hormone replacement therapy. The other thing is, if you're 15 years, 10 years out of menopause and you're, having new onset of some of these symptoms, I mean, a lot of women were just denied hormones going through that transition. But I do find now that I get patients who come in and say, oh, well, I'm having hot flashes now and they're 15 years post their last period. And you're kind of like, well, I don't know that your hot flashes now are due to hormones anymore, and that's something that would require more of a workup.
I was thinking more things like protective things like joints and that kind of thing.
Yeah.
And, like how you say,
Yeah. I mean, I think it can be helpful, and I think that it requires individual risk assessment just based on your history and your health at the time of initiation. But I do think that it can still be beneficial for those things.
Are there any studies? I mean, it's,
I mean, a lot of it is just reworking old data. Yeah.
Okay, thanks.
So I would say symptom onset is probably a good time to start. And, if you are in the throes of it and you haven't reached out to a provider or, you're not sure what you want to do, I mean, it's always, not a bad idea to go chat with somebody and see what might be right for you. So I wanted to jump for a minute and just talk about types of sexual dysfunction. Not to harp on this, but I do find that like I said, this is something that I find is one of the more distressing aspects. And so for women, there's more types of sexual dysfunction than what's up here, but I think that the two that we can kind of affect are interest and arousal disorders and pain syndromes. And pain syndromes can predate menopause, and I think that pain syndromes for women are often bimodal in that young, healthy women start off with pain with intercourse, and they really have not a great idea about sex. And then as we get older and we get into the perimenopausal period, that's when some pain syndromes can kind of come back into play. And then the interest and arousal disorders we talked about can be definitely multifactorial. And I mean, there's all these things that can contribute. Poor sleep, alcohol, other drugs, smoking. Those can all affect your interest and your drive and your ability to be aroused. Hormonal imbalances, chronic illnesses, certain medications. We talked about the SSRIs. That's definitely not an exhaustive list. There are many medications that can affect libido and arousal, and then all these psychological things that women are, can be going through during the menopausal time. So there are medications that can be helpful for this. If you're on an SSRI and you're not on it for vasomotor symptoms, but for a mood disorder, Wellbutrin might be, bupropion might be a good alternative for you. There are some side effects, as always. These are some of the more common doses. Flibanserin, I have never prescribed. This is a serotonin agonist. You take this at bedtime. There are some side effects here, but it has been shown to be effective. And then testosterone, we kind of talked about this a little bit too. On the right is some reasons why we wouldn't want to do oral testosterone and use these pellets. I think, honestly, if you have good oversight and you want to try some of these, off-label, because they're not FDA approved, I don't think it's a wrong thing. I just think that you need to be aware, that you really want to keep an eye on your levels and make sure that you're in the right range, because it can have irreversible effects and other long-term health effects. But this is some of the, so it's a 1% cream or gel applied daily. It's about, a tenth of the ml dosing for testosterone. It is effective. I mean, a lot of women find that testosterone is effective at increasing libido, but I think it's also important to note that there are a lot of factors that go into libido, relationship with use, self-image issues. I mean, there's a lot of other things besides just hormones that go into that, and especially during this time, when things can be stressful, you're managing a lot, and so I just, I just pause and say, let's look at the whole picture here for the testosterone supplementation before we jump to it.
So why don't we talk about it more? Why are a lot of us middle-aged women here attending a talk about the basics of menopause? Why have we not received this education previously? That's an assumption I'm making that I'm guessing is true. I think there's a lot of reasons why that might be the case. One of them is that, we don't always have the available evidence to talk about what we know about this, so we need an increase in the research. There's also stigma associated with talking about women's body and bodily changes, and I think that menopause is often perceived in the whole process of perimenopause, et cetera, is perceived as something negative that people might feel shame about or not want to talk about openly. And so in addition to, I think, a million other reasons that we don't want to talk about this. And also some of it is uncomfortable, right? Like not everyone wants to talk about their decreased libido in any sort of setting. Right. So it just might not be easy to talk about, or we might not live in a social world where that is easy for us to do. But I do think more and more people are talking about these things. I think that there is more research that is being done. We are starting to have a better understanding of what this looks like and what kinds of treatment options are available. And that's good. And you are all here, and that is good. So people want the information. It's just a matter of getting access to that information. Menopause has a bad rap, I think. People tend to, at least in my social circles, anecdotally, it's like no one seems particularly pumped about it. I mean, we talked about like, yay, no more periods, but like there's a lot of booze associated with it as well. And I put like, aging sucks. Is it just a part of this idea that like, especially women become more invisible with age? We're not represented. We don't see older women around places. Like, is that part of this? I imagine yes. I put that question mark there just because I talked about like the subjective experience of menopause, of these impacts. There are things I love about aging. Like, I know myself so much better. I know what I like, what I don't like. I have so much more knowledge about the world, about my experiences, about the people that I love. I mean, all of those things are incredible and they come with age, right? I don't love all the things. Like, I'm way slower at running now. That's a bummer. You know, I know that I'm surrounded by a world that values youth and beautiful people, and so when you don't fit that, that can feel hard. So like, not all great, but there are really great things about it, and I think we need to talk about the great things about it more because it's not all bad. Oh, and cross-culturally, not everyone has the same experience, and so we find in different cultures, women experience menopause differently based on a number of factors. Social isolation, generally that's not good for your experience of menopause. People living in multi-generational households where they see that directly and they can have those conversations, better experience with menopause, right? Like, those things make intuitive sense. So when it's not talked about, when it's kind of seen more as secretive, worse outcomes. In Japanese, kaniki is the term for menopause, and it means like renewal season, energy, so like definitely viewed in a different light than menopause, which has, which in Arabic translates to the age of despair. Yeah, right, like doesn't feel good. I just learned that and I was like, bummer. Like, we need to rebrand because it's not helping our experience with this.
Or just feeling like hysterical, and how the term hysterectomy came about. It's like, we are going to cut out the hysteria by removing the uterus, you know? I mean, I just think it's, you know, it's a real feeling that you know, we're trying to wrestle with and come to grips with, but.
So what now? Like, what do we want to happen? How could things maybe be a little bit better for us? I mean, we talked about some of the treatment options, but just as far as like, what do we need? We meaning people experiencing this phase of life. Social supports are really important. Studies show that that is a big factor in contributing to a positive experience with this. Partners and spouses play a really big role in this. Like, that was a very big predictive factor in systematic review that I read. So being supportive. We were kind of chatting earlier about this and how like similar to like people are like, what do I say? Like, how can I be supportive? I think similar to how we talk about like how to discuss PMS, right? You never want to like invalidate someone's experience, like, oh, you're just being perimenopausal, right? Like, boo. But you do want to be like, oh, I understand that this might be impacting your experience. Like, you might be feeling this way because your body is doing things, right? And so being understanding without being invalidating. Sisters, mothers, friends, we talked about that. Community, you're all doing that. You're also doing number 2, information. Information is really big in improving people's experience with this. So understanding what it is, right? And so like even recognizing what the symptoms are, if you start experiencing things and being like, oh, maybe I don't have to have low libido or whatever it is, right? Like maybe there are treatment options, or maybe just talking about it with people will be helpful for me. And then also the medical supports, so having access to healthcare, access to providers. I mean, we have great providers in town, but we also have a limited range of types of providers, so we don't have everything that someone down south might have access to. Speaking of supports, a plug for Amanda Schuler's resistance training class. She teaches one at the rec center, and I asked her about her upcoming schedule. So she does 2 different classes. She does one for like menopause age range, and then she does one for like older women who have already experienced menopause, or postmenopausal. It's more like osteoporosis focus is what she said. And you have to take her like intro class, and she's not offering that again until September. So if you're not already enrolled, you might not have to sit tight, but all of that information is available through the rec center. And so that really is focused on like bone health and on people that want to start resistance training, because studies show that especially in this age range, strength training, resistance training is more important for like mood stabilization and managing symptoms than like cardio. So like lifting weights may be better than like running at this phase in our life. Okay, so that's what we need on an individual level, what we need like on a global, macro level, access to information. So we need more ways to access information for everyone, not just women. We need more comprehensive and accessible treatments, which requires that we have more research. So there's just a dearth of research. We just don't know. So like people asking questions like, well, what if I want to do this? Or what if this is my situation? We don't always know. Like we just don't have the answers because the research has not been conducted. And so in order to be, I think, a responsible provider, you need to have the evidence. And we don't have the evidence right now. Normalizing the experience. So again, that opposite of social isolation is talking about it, normalizing it. And then having more policies and supports, so like workplaces that understand. I mean, workplaces have been, I think, more accommodating towards like breastfeeding mothers in recent years, right? Like that is considered something that workplaces have to accommodate. I mean, what if we looked at this perimenopause process as something similar to that?
Say, all you women, you go sit in office and you work together by yourselves.
Here is the thermostat, adjust as needed. Like, you want more, yes. I've heard some kind of really unhelpful sources of support that people have received that feel dismissive. Like, oh, I'm having hot flashes. Wear layers. I mean, not bad advice, but like not sufficient advice.
Yeah. I'm using to run in a tank top with my gut hanging out because of hot flashes.
Is it all bad? So, as I've kind of alluded to, no, it's not all bad. Margaret Mead, famous anthropologist, made this term postmenopausal zest, like living your best life. When your periods are done, you don't have to worry about that, not concerned about unwanted pregnancies, like just feeling great. And so this is the experience for some women, not all, it's not universal, but this exists, right? Like we potentially can attain this. And so I think that really is important. And for Margaret Mead, apparently, it was a period of unprecedented clarity, boundary setting, and personal power. We aren't fading away. We are stepping into a version of ourselves that is no longer dictated by a cycle. So framing and how you are approaching this is important to what your experience is going to be. I don't know, can we show a little video clip, Kathy and Leanna? There's a little link there.
Is it?
It's just right there. Sorry, I did not prep you on this, but I think it is important that we end on this positive note. This is a documentary. Highly recommend. It's on Canopy. Do we get access to Canopy with a library card, Kathy? No. You got to get on your own.
The public library might. They did at one point.
Yeah,
Ooh.
they have some amount of package.
Check that out. This is just the trailer.
Is this just a trailer?
This is just the trailer, so it's just 3 minutes.
Okay.
But I love this. I used to show this to my classes because I had access to the full documentary. It brings me joy. It gives people that may not be looking forward to this period of life. Oh, it's not taking, sorry. I think it's just at that New Day Films. That right down there. Yeah. Sorry, I thought that should have taken us directly to it. It's worth the additional clicks.
Sex is pure joy. Even bad sex is better than no sex. Yes, I still feel sexy all the time. And I'm horny as hell.
I'm 73 and he's 26. And I have never been more compatible with a man in my life. Yes, a lot of people think it's disgusting that I have a young lover. I don't give a rat's ass.
Margarita teaches me that I should not have sex and not be married. So that's a sin that I'm doing. But I also know that no one's perfect and that God will forgive us for our sins. So I'll leave it at that.
I have to say, there are times that Dolores and I walk down the street and we are thinking, these folks here, the people who get up to give us a seat in the bus, have no idea what hot numbers we are in bed.
Grandmother with her many years. They are evidence of the flow of time and of an order of events by which time can be measured.
I think society does have a hard time with the fact that I am not only a grandmother, I'm a great-grandmother, and I'm still very sexual.
What about the future of the menopausal woman? Is her creative life over just because she's reached the age of 45? The problem is menopausal women are constantly under evaluation. by clinicians all over the country.
Wouldn't that be
You
lovely?
become much more sexual after menopause. I mean, it's something that women are really being confused about, and it's being hidden from them, I think.
I found that the yearnings were still present. And at first I tried to ignore them and think, oh my God, you're much too old for this. But then I thought, you know, why would I be feeling this if my body was too old?
I thought, okay, menopause. It's supposed to be all over. I don't think so. I think I'm going to really get involved with some kinky stuff. I've never done this.
First of all, the psychological factor that you don't have to worry about getting knocked up is a big factor. And second of all, that testosterone thing just gets you hotter all the time.
What we think sex is about in America is a joke. It's a joke. There are all kinds of sexual things going on.
One way to take it.
Right. Right. Clearly not a universal, but this exists. People do have this experience. So I thought I think we can stop it there. I don't think the rest of the
There is something about sexual.
But yeah, it is a great film, the whole thing. So yes, that we wanted to end on that note because it is uplifting and heartening. But if folks have any questions that we didn't have a chance to answer from surveys or that you would like to share, I don't know if Kathy saw any more come in. If people need to leave, it's after 7, if you need to leave, I'm not insulted by standing up and going, but if people want to stay and chat and ask questions, I can answer those as well.
Do you have the questions from the?
I printed off all of them, but there were 2 new questions.
Oh, I'll come grab that. Okay. How long can a healthy person take estrogen?
So this also is under development, but it looks pretty promising that you can be on it for as long as you want to be on it. It's okay.
But it matters when you start.
I mean, again, that's still kind of up for debate, but I do think that as we talked about, that if you had a, comprehensive health assessment and you decided with your provider that, 10 to 15 years after your last period, if your natural menopause is kind of where the question mark is, if it's safe to start at that point. But I think if you have a risk assessment and it is, favorable, and your cardiovascular risk and your breast cancer risk are reasonable. Yeah.
Okay, we talked about this, but yes, how does taking birth control affect perimenopause?
So I don't think that it does. I don't think that there's any good evidence that it does. I mean, theoretically, you're not ovulating every cycle if you're on traditional systemic birth control versus like an IUD, which is more localized. But no, I don't think that evidence has shown that it affects the age of menopause.
And then we also talked about how there's no evidence to suggest the age of your first period, menarche, is at all impacts when you're going to experience menopause. There's not like you menstruate for this many years and then it's done. Like there's not a standard length. So that doesn't really give any information about when that's going to occur for you. And that taking birth control doesn't have an impact on like timing or anything either. It just might have an impact on some of the symptoms that you experience, right?
Yeah, I mean, birth control can mask the symptoms or treat the symptoms of menopause for sure, yeah.
Okay, targeted ads for women in perimenopause. What are things to look for to tell what might be valid, what might be more predatory?
I mean, you had a pretty good answer to this.
I mean, we were talking about this yesterday. If they're trying to sell you something, I think they're predatory. Which doesn't mean I'm not going to try it, but it means that I'm going to be skeptical about it because they're trying to sell me something, right? So they're like, this works and it's going to make you feel like you're 20 years old again. Like, probably not, but maybe there's something to it, right? And so like being mindful that's my stance on it, that I'm going to be skeptical and finding any supplement, and also being careful because I think we have a tendency to equate natural with safe. and healthy, but there are a lot of like natural supplements that can have negative side effects, or that can be, in certain doses, may be dangerous. And so just being like an informed consumer of those things. Are there research studies? Who conducted the research studies? Were they conducted by the person trying to sell them to you, or were they conducted by someone independent, right? So there's ways to kind of vet the quality or the evidence that does exist, but there's no one way to do this to know what's going to be good or not.
And it's nice to at least have them have resources for where they get the evidence that it works, have some type of resource or study that they're showing.
Are there foods that can balance your hormones?
Yes. I mean, I think it's hard to know how much you would need to take, but there definitely are phytoestrogens that can be beneficial. I'm sure that there's some foods that are progestogenic also, but I don't know those off the top of my head.
Yams are supposed to be good. And
Yeah.
soy.
Yeah, soy is a phytoestrogen, and that's, so talking about like cross-cultural studies, in some parts of Asia, they do find that overall the experience of menopause seems to be a little bit more mild. The symptoms seem to be a little bit lesser, and one of the reasons that is believed to be is because of their higher rates of phytoestrogens, like soy products. But that's just one factor. They're also less social isolation, but yes.
The reason I ask is I saw a naturopath at one point when I lived in Oregon. She was having to do certain seeds.
Oh,
before
seeds, yeah.
Where I was, because I was having heavy periods and stuff, so, but I never really thought it made a difference.
Yeah.
Well, and that's a good way to judge, right? Like, I mean, that your body won't necessarily feel the effects immediately, but like, this isn't doing anything.
I mean, also some of the plant, like specifically from the plant, not plant derived and modified and concentrated, but you do have to take them in such a high dose for them, such a large amount to really get a benefit that it's, can be impractical. I don't know how much soy you'd have to eat to get, really a result. But can increasing your phytoestrogens help? Yes. Do you need a progesterone if you have a uterus to kind of offset that? I don't, again, that's stuff I don't exactly know the answer to.
How can people who have friends experiencing menopause help out? I mean, does anyone want to answer that? I feel like we've covered that some. Any ideas?
You're not crazy.
You're not crazy. Yeah, that's always nice.
We're not taking things personally. When your friend who's normally like pretty solid kind of goes off the handle, like, that's not you. Don't be mad. It's okay. We're just like going through it. I mean, like any phase of life, anything that you're going through that may not be totally positive can have you just not acting like yourself. So I don't think it's specific to menopause, but that's where the communication is really helpful, so that people can kind of understand where you're coming from and can be a better friend.
Yeah, and I think I'm also thinking of what you were saying, women coming in with low libido and the guilt that they might experience along with that. So having, if you have a partner that is experiencing low libido, having communication around that. Because that guilt can probably feel worse than the low libido, right? So like that requires communication and conversations around that and finding what might be a solution.
I think, also, I appreciate you are a hard worker, but I think that a lot of times women are not they're being diagnosed with other things. It's really,
Yes, agreed. And I think sometimes then they're given like this Band-Aid that doesn't fix like what is actually the underlying cause.
Dr. Ziegler, can you repeat their question?
Oh, that women may be misdiagnosed, or they might, you come in. I mean, I'm thinking, yes, I try to be mindful of this, like when I am practicing. If someone middle-aged comes in and they're like, all of a sudden I'm experiencing rage and I hate my partner and I never want to have sex, I think it'd be important to be like, rather than being like, oh, I think you're depressed, which maybe you are, maybe you might want to check in with a provider and see if there might be some hormones underlying those changes that you're experiencing. And depression rates increase during perimenopause, and that's even for folks that may not have had an experience with depression prior to that. So like across the board, people are more likely to experience depression at that phase, even if they don't have a personal history there.
But I don't think the mental health practitioners know that.
Oh yeah, I agree.
Especially if they're men.
Yeah, they don't know that.
So,
I mean, hopefully that's getting better. Hopefully that's getting better.
But like, I had no training on
I'm
menopause as a,
I
I also
have
didn't
to say that I did have some training in residency in a women's health field, but I do not think it was adequate. Like a lot of the stuff that I'm like learning and practicing are because I've read and I've talked to other providers and I've, so I think even training is not great, even in the women's health field, honestly.
That would be my personal experience.
Yeah. Yeah, question back there.
Yeah, I'm curious, you touched on, like, and the average was 51 for starting menopause. What about the other end? Like, what are like the top ages? Like, where you start being concerned, like, hey, this isn't happening yet. Like,
That's a good question.
These periods just keep on coming.
When is it gonna stop?
It's true. I mean, so 55 is kind of like but honestly, if women keep cycling and they're cycling regularly, I mean, I still think I check in, get a pelvic ultrasound, maybe check your hormone levels and,
yeah, my mom was like in her 60s.
Yeah.
I was horrified. I was like, what?
Yeah.
60?
Yeah.
Yeah.
I mean, it can happen.
Yeah.
There are outliers.
Whether that's a good thing or a bad thing, I don't know. Some people might think one way or the other, but it can. I mean,
well, I went to I was helping clean out the bathroom, and I was like, what? And I go throw those out. She's like, no! I still need those. And I was like, wait, what? I still need these?
Yeah. I mean, hopefully that just meant that she had no symptoms and went, no, yes? Yeah, I'm unsure. Yeah.
Well, that's why we need to talk about it more, right? 'Cause I don't know what my mother's experience was. I wish I did, but I'm gonna know my sister's experiences, right? Like, we're going to have those conversations. The other two questions on here are about like weight gain, which I think we kind of touched on. Metabolism kind of slows down. HRT isn't going to fix that for folks.
It might slow it down. It might give you more resources to make better decisions and more energy to do it. But hormone replacement is not going to take 20 pounds off that you've, put on through the process, or that is just normal, menopausal or aging rather. Yeah.
And the research really talked about the importance of, because bodies do change, right? Like that is something that happens with age. Being able to focus on your body's ability to do things is a helpful perspective shift rather than focusing on what it looks like. And that's actually true across the lifespan. Like even like teenagers are better off if they're thinking about like how much they can lift or how many soccer balls they can kick or whatever sport they're doing, than like what do I look like. And so in general, that is a more positive way to approach like your body and your fitness. Yeah.
What if you're somebody who has ended up with high testosterone while going through the perimenopause?
Like Harriet?
That can happen. There can be a shift to more androgen production, and I don't know off the top of my head if there's different health outcomes for women who have higher testosterone as they go through menopause, but yeah, I mean, I would say that hopefully that means that there's no libido issues. You might have better metabolism. I mean, I'm sure that there are some effects.
Metabolism's tanked.
Yeah. Other questions?
Oh, yeah. I have a question. Actually, I have two. So when I got diagnosed, well, I didn't even know I went through perimenopause. I'm postmenopausal now. And the doctor recommended that I just take estrogen. She never ever told me about hormone therapy or whatever. Is
estrogen an over-the-counter?
Yeah.
Yeah.
It's like an over-the-counter thing. And she's like, it'll help with hot flashes. And it does. It has helped. I mean, I don't have an issue. But now my other issue is I have frozen shoulder. So I keep reading about how that could be a symptom of menopause, like losing estrogen and that affects your like muscles or something. I don't know.
So maybe that might also be aging and not necessarily menopause. And I think it's tough to kind of differentiate the two. But I don't know that, a decrease in estrogen affects, your ligaments in that way.
Okay.
You can have, muscle aches and joint aches, but not necessarily like physical problems with your tendons and your ligaments per se. Yeah.
But do you think, it's okay to just keep taking the over-the-counter, or would you recommend just doing the hormone therapy?
I'd like to know more about what you're taking because I'm not familiar with that over-the-counter, and just to know what's in it.
It's called estrogen. I don't know. It's just like a plant-based type thing.
Yeah, it might just be phytoestrogens, but then I would wonder, what are your actual estrogen levels, and do you need something to protect your uterus? Yeah. So, you might consider hormone testing, or if you just wanted to kind of make it easier and take something that's transdermal, which seems to be safer anyway.
Yeah.
And just get on a regimen. But, yeah, I would say get your levels tested, or have somebody take a look at what's in there. Yeah.
Question over here, yeah.
So when an endocrinologist tests your hormone levels and finds that your testosterone is 45 and it's supposed to be down 20 or something for your age and body type, once that's adjusted, does it go away? Or do you have to go in periodically, or how does that work?
Testosterone. So if you have high testosterone levels, you find out from testosterone testing, you take something to lower them.
Right.
Do your symptoms go away? Do you have to maintain the taking of the whatever to lower them? Is that kind of the question?
Yeah, that's kind of the question. It's like once they're adjusted, do
Yeah,
they stay that way?
Yeah.
Is it like chiropractic? Do you have to go in periodically?
I think that the levels probably fluctuate through the process, and that at the end, testosterone is likely not going to remain elevated, especially if it's in the perimenopausal time. That's a transient increase.
But if it's postmenopausal?
If it's postmenopausal and you have higher levels of testosterone, but they're not really through the roof, they're just slightly elevated. I don't know that there's a medication that would actually lower the testosterone. There's so many things that can affect that. Sex hormone binding globulin is one of them, and do you just increase your sex hormone binding globulin to get testosterone, the free testosterone that's effective for your tissues, to get that decreased. I don't know necessarily that anybody would try to decrease your testosterone if it's just slightly elevated, and slightly meaning not 1,500.
Well, if it's supposed to be like 20 and it's 45, is that slightly elevated?
Yeah, I would, even though it's double the normal amount, I would say, it's probably worth looking into and thinking about some of those things. You might find with that elevation, you might have nail pattern baldness. You might be having some hair growth that is not lovely in places that you wouldn't necessarily want it. But in terms of, real health effects long term, it's probably not going to be something that's elevated further. So if you have really high levels, you want to be looking for like tumors that are secreting testosterone or something like that. But if it's just your body making a little extra testosterone, it's probably transiently okay.
So I kind of like a multiple part question, but so for women having kids in their 40s or late 30s, and say you breastfeed for a long periods of time, you stop breastfeeding, so your hormones are going to change anyway, and you have hormone testing a few months after breastfeeding, and it showed, okay, you seem to be going through perimenopause, but since they fluctuate anyway, should you wait? Should you act on it? Should you just repeat every couple of months?
I mean, I think symptoms, the amount of distress that you're going through in the process, you know, I think that those all factor into the decision to get on something.
Or not even to get on, but like the FSH, is that one that fluctuates also? Or if it's showing your postmenopausal ranges, does that ever?
So usually in the perimenopausal time, if your hormones are gonna be like diagnostic for, you know, going through that process, you have an elevated FSH and a low estradiol is kind of the classic picture of menopause.
Oh.
So in that case, testing does indicate something?
Yeah, but I would say, so when I think about hormone testing a patient who's having symptoms, it's usually someone who's a little bit younger than what I would think it would be the traditional person going through perimenopause. It might be someone who's had a hysterectomy and they don't know what their periods are doing. It might be somebody with an IUD in place and they don't have periods, and so we're not quite sure what their cycles are doing. I would say by and large, if you are still having completely regular menstrual cycles, you know, it's possible that your symptoms are perimenopausal related, but it's likely that your hormone testing are not going to be irregular.
Oh, okay.
Yeah.
What about athletes who don't menstruate?
Athletes who don't menstruate, I think those patients probably, especially if they're young, should be on a birth control pill, something to keep their estrogen and progesterone at some physiologic level to help with bone health. Yeah, but I mean, if it's a long-term issue where they're like decades of not having periods or even, you know, more than a few years, I would probably recommend that they see an endocrinologist just to make sure that they're optimized and they're not having, you know, long-term health effects from that.
Could you give like a brief physiological explanation of hot flashes? Like, I know they're vasomotor, but like, what exactly is happening?
I don't know the
Yeah.
answer to that, like from a basic like biochemical, you know, standpoint. I always thought it was the elevated FSH levels that are really causing you to have those fluctuations. I think it's just general dysregulation of your like temperature regulatory center from the hormonal fluctuations. But if you wanted me to go through like biochemical pathways.
No, I guess just like, what is it that makes you feel so hot? Is it just increased blood flow?
No, I think it's literally, because you're not having a fever.
Right.
You just have the physiologic response of overheating. So the sweating and the flushing and so it is your central thermoregulators that are detecting.
So your brain thinks you're hot, but you're not hot.
Yes.
Okay.
Well, and
That's
is it
the
like
yeah.
stress makes you feel hot, right? Just like for an average person, like you get stressed out oftentimes, like you do feel more heated, but it's just like you're more sensitive in this perimenopausal stage to experience that kind of situation.
Okay.
This might be a crowdsourced question, but a hot flash, is it always too hot or are there cold flashes? Because I seem to also get the opposite reaction where it feels like a cold sweat except for there's no sweat. So instead of waking up in the middle of the night broiling, which also happens, I wake up in the middle of the night absolutely freezing.
It's not because you kicked the covers off and opened the
It's
window.
not.
Does she need more layers?
More layers. That's interesting. I've not heard much.
I have heard that
Cold flashes.
anecdotally. Someone
Yeah.
was actually just talking about, they were like, I have hot flashes and cold flashes. They had cancer treatment, impacted their hormone levels, and they were saying that that was something that they learned was a thing. So that, I mean, I'm
How about any
not
of
an
you?
MD.
Yeah, but I think it usually is like because like I have overcorrected. Like I have like stripped off all of these layers and stood in front of the fan and all of the things and then I'm cold.
Mine seems to be like the hot
Yeah.
flash where it comes out of freaking nowhere.
But I guess, yeah, but it's still just like your brain, your thermoregulation, like your
Yeah,
temperature.
I mean, that does make sense.
Yeah, it's just not as common.
And then I have a hot flashes question too. Are they always hot? Or like, I seem to get warm flashes. Where the thermostat says 73 in my classroom because the chimney is in our room. That's a whole nother story. It says 73 and sometimes it feels like 78 and sometimes it feels like 82. So like, they're not always hot flashes where I have to run outside, but it's like, I am stripping layers, but then I get down to the last layer and I'm like, okay, I'm good now, I'm good. You know, and it doesn't go all the way to the broiling point. Are all of these things just the same thing in different degrees?
A lukewarm flash?
Yeah. Just a warm flash that comes out of nowhere. Okay. I'm just curious.
I have a follow-up question on
Yeah.
based off of hers. How long do they last? I mean, how long is a hot flash? I mean, it sounds like, oh, I'm hot. And then I'm not, but I have no idea.
I think that's very just person to person variation. I mean, I think they can last as long as just a few minutes and they can be a half an hour, you know, long where you're just dying.
Okay, so flashing to marinating?
we do need a whole new vocabulary.
We just call it heat dysregulation.
Yeah, I
and
know.
it'll
Yeah.
cover all of it.
Right. I don't know where the term hot flash came from either.
But is it hot?
It's the speed at which it hits, not how long it lasts.
Other questions?
So if you've been on, put on an IUD and you haven't had a period in however long it has been, but would you recommend doing the testing of your levels?
I would say only if you're having issues.
Well, I haven't had any issues.
Yeah, I think if you're cruising, there's no need
Am I
to.
past that point now? Because of my age and I'm done?
So I think as time goes on and we get more evidence about the health benefits of hormone replacement therapy, you know, we may see that things change, that it's not just symptom management, but actually just something that we put women on when they reach a certain age for health benefits long-term, for bone health, or cardiovascular health. But we're not quite there yet. I don't know if we're gonna get there.
I was more wondering, do we need to test my levels twice?
If she's had an IUD in and not had periods, how does she know when she's in menopause?
Because she's got symptoms.
You would still.
What if she glides through with no symptoms? How does she know when she's in menopause?
And at some point, we decide to pull out your ID and see if you have a period.
I don't want one of those. That's why I got that.
I mean, if you wanted to, I think it would be reasonable to test hormone levels. Yeah, if you were just curious and you wanted to know. I mean, but then it would just be to take out your ID, right? Just kidding.
It has to come out.
Lana, is it normal to have your heart race or with a hot flash, or is that something that should be checked out?
It can be normal to have your heart race with a hot flash. If you are getting dizzy from it, or it lasts longer than the hot flash, you're getting independent of your hot flashes, you know, if you're having chest pain, those would be all things that I would say go get checked out. If you're just like feeling like you're having palpitations when you have a hot flash, that's fine. As long as it's not lasting, you know, half an hour, 45 minutes, you're getting dizzy, you're gonna pass out. Those are not normal things.
So if we want more one-on-one, do we make an appointment?
That would be lovely.
Yeah, there are a few providers that offer these kinds of services in town, right? Services meaning like?
Yeah, and I do think that some of the primary care providers, I know Stephanie Myers-Duggar does put patients on hormonal therapy. There are also providers in Seattle. There's a person, Dr. Timmer, who I find a lot of people from Ketchikan like to go and see. She's a naturopath down in, an actual doctor in naturopathy down in Seattle, and she does a lot of those She does the pellets and the troches
at
and stuff.
West Place.
Yeah.
Fireweed, some.
I think it's Sabrina Yoder.
Yeah, I think
She's
that's who it
a nurse practitioner.
And Andy
But she
Zink and
specializes something.
Patty
in
Thornton also do some of this. I don't think they
She's at Zink,
specialize
yeah.
like Sabrina, but they offer
Yep.
those services as well. So there are providers in town.
Yeah.
So there's other options if you wanted to ask them.
Just a fast commercial break. You can come up to the campus library and we will sit with you side by side and show you how to drive through the databases. So you're looking for those peer-reviewed articles out of scholarly journals. I mean, we really love to do that.
I love it.
I'll show you how to do it. The
Do
other
it.
thing, approaching my 66th birthday, it's great. It's great because you're a little more financially secure, and you give really less of about anything. It's a great time to run for office. So I'll just
That's what we need.
Yeah.
More 60-year-old women running for
Just,
office.
yeah, don't hesitate. There's way fewer boundaries. You can ignore them. What are they going to do to you?
I can't wait to get there.
Yeah, I think that we're at the end now. I am so grateful for everyone that showed up. I was really excited to get to talk about this because I think it's important and interesting, and I also want this information. So thank you so much, Nicole, for being willing to do this with me, and thank you all for bringing great questions and for showing up and for caring about your health and your community and all of that. And thank you to the library because I love the library and I love librarians, and you are so great. So thank you, everyone.
Are there any women's health topics that you guys would want to hear more about or think the community would benefit from?
Birth control options.
Yeah.
I know that my daughter went to 3 or 4 different people before she settled on one, including you.
Yeah.
And we ended up with, but maybe postpartum.
Yeah, postpartum.